Our next speaker is Jonathan Silverberg, and he will talk about irritant contact dermatitis in atopic dermatitis patients, something we see very, very, very often.
Excellent. Thank you so much. Thank you to the organizers for inviting me to present. So I think a lot of the concepts that I'm going to cover, you probably already heard a little bit about from the previous speakers. So I'm going to try to minimize some of the redundancy and cover some of the salient high-level points to think about. These are my disclosures. Probably none of them really, I'm not going to be talking about specific therapeutics, so I am certainly involved in many different trial development, but we're going to really talk about pure, gritty clinical characteristics or clinical concepts that we deal with. And, before I even get to any specific data, I think this is something, this topic, while, as Robert mentioned at the onset of the meeting, you can't get more clinically relevant than this. But this is not a sexy topic, and this is not something that anyone likes to address in clinical practice. Because it takes an extraordinary amount of time. You actually have to think out of the box. And thinking is not something that most doctors like to do in a very busy practice setting. They like to work by rote. It's hard. And our insurance system around the world doesn't really facilitate spending time with patients. So I'm going to talk about some of the data. But there's actually, it's funny, there's far more studies out there on allergic contact dermatitis in general and in atopic dermatitis patients than there are for irritant contact dermatitis, because it becomes a diagnosis of exclusion and the complexities, and these are often very challenging patients. So I'm going to start with, I think, one study from John Hannafin's group, which I think is a very important one. It's not a huge study, but it's a very simple one. They patch tested patients with atopic dermatitis to sodium lauryl sulfate. Now, in the old days, we used to think sodium lauryl sulfate was an allergen. Now we know it's not. It's really just an irritant. And they did a 48-hour reading for these patients. And what they found was that the rates of positive patch test reactions were higher in patients with atopic dermatitis than those without atopic dermatitis. But what was fascinating was they found that the rates were also higher in patients who had allergic respiratory disease, even when the atopic dermatitis was resolved. And so this really is provocative because it suggests that even when the atopic dermatitis burns out, so to speak, they don't have the active dermatitis, that sensitive skin issue can be lifelong. And this is really the reality. For so many patients, we'll see whatever the clinical scenario is that brings them in as an adult. Very commonly, we'll talk about hand eczema in particular in a few slides, but just as an anecdote, I'll have postpartum mothers coming in for evaluation of really bad hand eczema. And if you ask them, they had atopic derm early in life, they've been clear for maybe decades, but now they're using wet wipes much more and getting exposed to all kinds of fun stuff in the diapers. And so all of a sudden they can break out with hand eczema. That sensitivity, though, was always there. So, some of this leads to some classification issues. What do you even call this? What do you define this as? Should you call it atopic derm? Should you call it irritant contact dermatitis? That I would argue that's the most pure definition and classification. But it's debatable, right? Because where does that lower threshold come from? It comes from the atopic dermatitis. There we go. So we've got some additional studies as well. And these are, some of these studies are fairly old. Again, it's not a very sexy topic to look at in the modern era. But in non-occluded application, it was found that transepidermal water loss was greatly increased by exposure to propylene glycol. And in patients with atopic dermatitis, but less so in non-atopic dermatitis controls. I chose this, and there's many studies I could have chosen to illustrate this point, but for anyone in industry who is developing topical therapies, please don't put propylene glycol in if you can. I know it's an ingredient that everyone likes to use for a number of beneficial properties, but it's really not an ideal ingredient for the atopic dermatitis patient, both from a allergic contact dermatitis perspective and even from an irritant contact dermatitis perspective. And then response to sodium lauryl sulfate in a separate study was significantly increased in atopics compared to controls when evaluated by visual scoring and skin thickness, but not transepidermal water loss. And this actually inconsistency in findings, not just from this study, but there are other studies where, depending on how you measure this, you see irritation, or you can find positive findings with one measurement, not with another's. It's not always easy to assess irritancy in clinical practice and in clinical research, but the inconsistency of findings has led some authors to conclude that it's actually really complicated, the mechanisms and the relationship between atopic dermatitis and irritancy, that it may not just be as simple as lower irritant thresholds, but in fact there may be a behavioral component and other aspects that factor in, right? Because patients, it's not just that they're getting exposed to one ingredient, they may be getting exposed to any number of cumulative exposures, they're applying myriad products to treat their underlying disease, and so it turns out that it's actually quite challenging to pinpoint exact mechanisms for in individual patients. So you got to see a systematic review of allergic contact dermatitis in atopic dermatitis. Well, this is a systematic review that examines skin absorption through atopic dermatitis skin. And of 40 different studies, it was found that there was increased absorption in atopic dermatitis lesional and non-lesional skin compared with controls in multiple studies. And what you can see in the graph is just that ratio between skin absorption in patients with atopic dermatitis versus healthy controls. And so it differs depending on the ingredient. But we see that across multiple different ingredients tested, that there is this increased absorption. Now, why does this matter? Well, this is a highly relevant concept, and it was already addressed, I think, by Mette, and Emma already alluded to this earlier. It's not just relevant to irritant contact dermatitis. It's also relevant to allergic contact dermatitis. There's long been a debate about why patients with atopic dermatitis, first of all, whether or not they do have increased allergic contact dermatitis or not, but even if they did, why? And there's this sort of competing effects. But what everyone can agree upon is that there is this barrier disruption. And that barrier disruption can happen even in non-lesional skin. And with that, you've got increased penetration of different ingredients. Now, what effect those ingredients will have may vary by patient underlying sensitization, right? For some patients, that might be allergic contact dermatitis reactions that are triggered. And for others, that may be just more of an irritant reaction. And we'll talk about some of the differences in characteristics. And some studies even found increased systemic uptake of topical corticosteroids in atopic dermatitis, which is relevant for other clinical purposes, right? When we talk about application of topical therapy, this is sort of like, one of those dirty little secrets in dermatology. We always assume, or we pretend, that when we counsel patients that there is no systemic absorption, but the data show that there is, certainly for topical steroids and with other topicals. And we hope that it's negligible, and we hope that it's transient, but it is there. And so this concept is not just relevant from an irritancy standpoint, but it is certainly relevant from a systemic exposure perspective as well. Now, what about, when we think about irritant contact dermatitis, it's such a broad bucket, if you will, right? Because there are so many different ways in which someone can get exposed to things. You've got certainly what I see a ton of, personal care products and topical medications in the atopic dermatitis patients. But we know that, depending on the region, there can be a major problem of occupational dermatitis, occupational irritant contact dermatitis. Now, that can be allergic, it can be irritant. This is on study in Germany, a case control study that looked at patients with occupational irritant contact dermatitis versus controls. And, trying to understand what those risk factors are, why, some patients are more likely to have irritant contact dermatitis. And, this is flagrant loss of function mutations was one of the risk factors that were demonstrated. And this is work that has been done by multiple groups throughout Denmark and Western Europe, showing the importance of filaggrin mutations for irritant contact dermatitis and a variety of other different types of dermatitis. But self-reported current or past history of flexural eczema as a proxy measure of atopic dermatitis was also shown to be associated with higher rates of occupational irritant contact dermatitis. And actually, the effect size was even greater for the history of atopic dermatitis than it was for the filaggrin null mutations, which might actually seem counterintuitive, but in fact, it's the clinical history that's going to be far more meaningful than doing the genotyping exercise, which in the U.S. we don't have really any commercial or even research access to the genotyping exercise in any regular way. So we see that atopic dermatitis is associated particularly with increased occupational irritant contact dermatitis. Now this is certainly very important. What do you do? How do you counsel patients on this? And there's no right or wrong answer. Or at least there's no standard answer for this in the field. I've had patients ask me to purge their medical record of their history of atopic dermatitis so that they could go into a certain career, particularly as it pertains to active service in the military. Because if there's a history of asthma or a history in particular of atopic dermatitis, they may be out because they can't get a smallpox vaccine. So this is very tricky, and there are plenty of occupations that are, as you heard about, right? Going into botany, probably not a great idea for someone who's allergic to plants, but what about so many other occupations, factory work, et cetera, or wet work, cement work, et cetera? There's numerous different potential applications where irritant exposures will happen. Should we be telling patients to change their entire life trajectory to avoid this type of situation? Some will inherently do this. Having conversations with Jacob Thiessen in Denmark, he jokingly says, most atopic dermatitis patients will find their way away from the wrong types of exposures, and they'll choose a career that'll keep them away from this stuff. But actually, you see here from this study that there's plenty who are getting exposed and are getting that kind of occupational exposure and irritant contact dermatitis. So I think there's a lot of questions about what do we do with our younger patients? Should we be counseling them? We don't want to take away their hope, but at the same time, right, this is something that they need to be aware of. And it also illustrates that these irritant exposures can happen well beyond just a house, well outside the personal care product realm, which is often what we think of most for the atopic dermatitis patients, but certainly in the occupational setting as well. Now, you heard Emma mention this earlier about the complex overlap between atopic dermatitis, irritant contact dermatitis, and allergic contact dermatitis. And I could have cited any number of a dozen studies that address this. I'm just showing you data from a recent study that I had the privilege of taking the lead on, looking at data from the North American Contact Dermatitis Group, which is a consortium of patch testers throughout the US and Canada, and particularly focusing in, this is looking at adults with hand eczema, right? So now we're getting into specific sites. There are many, irritant contact dermatitis can manifest almost anywhere on the body. All right, any place where someone might get exposed to something, right? That's pretty vague and pretty broad. But the hands are a very common site of allergic contact dermatitis and irritant contact dermatitis, and it makes sense why, right? Because our hands are coming in contact with all kinds of junk on a daily basis, on a minute-by-minute basis. So this is one where we really wanted to understand, in particular, within that hand eczema patient population, some of that complexity. Hand eczema, as many of you know, is starting to heat up now as a therapeutic target. But I don't care how good a drug is, if you're not addressing some of those environmental triggers, it's going to be really hard to achieve control. So this is actually a very important issue. It just doesn't take a sidebar from what's on the slides, but first of all, many would argue, why are we treating something that might be environmentally triggered and can be avoided with some new medication. And I think there's some merit to that argument. On the other hand, for many patients, they'll develop chronic disease even after you avoid those triggers. But it really is imperative upon us clinically to try to identify what those triggers are and remove them as best we can. So in this study, we found substantial overlap between the different etiologies, different final diagnoses for patients with hand eczema. So most were diagnosed with allergic contact dermatitis. Not surprising, right? There's a referral bias. These are patients who were referred for patch testing. It doesn't mean that every hand eczema patient out there is allergic. On the contrary, we believe that the majority of contact dermatitis cases are going to be irritant in nature. Followed by, after allergic contact dermatitis, would be irritant contact dermatitis, and then atopic dermatitis, and then dyshydrotic eczema or Pomfilix, which is in of itself a controversial entity that we're not going to touch upon for today. But there was this complex overlap between them. And for some patients, they had allergic contact dermatitis with irritant contact dermatitis, but no atopic derm. Some had atopic derm with allergic contact. Some had atopic derm with irritant contact. And this is what we think about. In history of atopic dermatitis was associated with increased irritant hand eczema. Patients who were patch tested and found not to have any relevant allergic reactions. Now, it's not this astronomical effect size. You're not seeing a tenfold higher odds of irritant hand eczema in these patients, but it is significant and it's there, and it's something we deal with routinely on a clinical basis. This is just something that, some examples of patients that we see. And, this gets back to something that I was mentioning beforehand, which is semantics. What do you even call some of these patients? What is the right code or classification or diagnosis? In adults with atopic dermatitis, all the literature has shown that hands and feet are much more common distribution to be affected than in children. It really starts, if you look at the prevalence of hand eczema in atopic in general, but in the atopic dermatitis patient population, you see it starts to pick up in adolescence, and then it really kind of skyrockets in adults. Why? What is this? Is this an evolving pattern or phenotype of atopic dermatitis? Some have argued that. Or is this just, no, you're getting more exposures, irritant exposures, allergic exposures that are setting this off. These are some cases of patients who had hand and foot involvement who did not have relevant allergic reactions. For hand eczema, we often see worsening in wintertime, triggering by hand washing and a variety of other irritant exposures. Has become, just as an anecdote, I saw more I've always seen a lot of hand eczema, but post-COVID, like in the initial throes of the COVID era, I can't tell you how many healthcare providers I saw with hand eczema. So at some point I started asking them, how many times a day you wash? I wash my hands a lot. Sometimes they tell me I'm washing my hands like 10 times a day, which is not that much for a healthcare provider. And I said to them, well, what were you doing before the pandemic? Were you washing your hands at all? And many of them actually were just honest and would say, no, I really wasn't. I really should wash more. I'm not so good with it. Anyway, but this is, now in the pandemic, it certainly has become a very hot topic. For foot eczema, there's different profile of exposures, but also different types of irritants, certainly from personal care products. But there's also a lot of friction, wear and tear, heat and sweat that happens, particularly from occlusive shoes. And again, what should you call this? Is this just atopic dermatitis, or is it not? Is it just irritant contact dermatitis in someone who's got a lower threshold for irritancy from their atopic derm? I mentioned that point a few times because if you actually try to look at some of the health services research, and if you try to actually do some of the epidemiology work behind hand eczema, it actually gets really complicated. It's a big hot mess when you look at claims data. A lot of patients who are labeled as atopic dermatitis in adults really, if you look at their charts, just have isolated hand eczema. It gets very complicated, and it's debatable. Do they really meet criteria or not? And sometimes these are very fuzzy definitions. All right, what about children? We see a very similar story. This is a repeat exercise we did from the North American Contact Derm Group data, looking at children with hand eczema. And also, same story, complex overlap between the different etiologies. And in particular, in this study, we looked at what were some of the most common classes of irritants to be problematic for irritant hand eczema. And perhaps not surprising, but it's worth discussing, we certainly see soaps, detergents, and cleansers that are used for personal hygiene, shampoos, conditioners, moisturizers. But then we also see things like gloves, water exposure, wet work in general, as we expect, cosmetics, etc. And one of the things that was actually very interesting about this study, which got many of my colleagues in the North American contact dermatitis group puzzled at first, but then we talked it out and it made sense, was occupation was also a risk factor for hand eczema in the pediatric age group. Now, that would seem like obvious if you were talking about adults. We know that occupation is a major risk factor, but we often don't realize, and maybe I see a very international audience here, maybe what I'm saying is obvious, but to my US and Canadian colleagues, apparently children are really spoiled and don't ever work, at least in their mindset. Maybe it's true everywhere, I don't know. But so they're like, nah, kids don't work. But actually, the ones who had jobs had markedly higher rates of hand eczema, and in particular amongst those who had that atopic background. So I'm not suggesting that children should not be encouraged to have work ethic, but we do need to advise them that if they're going to take like a summer job, even for part-time work, this is highly relevant to them in terms of being careful about what kind of exposures and work they're going to be getting. What are some of the clinical characteristics of irritant contact dermatitis? And you heard about some of this already, some of these contrasts. Before I even say them, just to point out, absolutely none of these are hard and fast rules. These are all just general observations. I've seen every single one of them fail repeatedly, okay? But they're things that we in general think about and look for. So certainly dermatitis with sharply demarcated borders, and if it's going to be localized to select sites on the body, that should raise your suspicion for contact dermatitis. Now, that's all it's going to be able to essentially do. You have to take it one step further to then be able to differentiate, are you talking about irritant contact dermatitis or are you talking about allergic contact dermatitis? Some sites, there's many others, but some sites that come up would be hands, face, eyelids, are all some interesting sites that we think about for allergic contact dermatitis or irritant contact dermatitis. The irritant contact dermatitis tends to be more localized to the site of exposure. You don't see as much of this sort of spreading reaction beyond, and you tend to see less of this sort of id reaction, this sort of generalized isomorphic reaction that can occur. But even this, I have seen patients where after all was said and done, I was pretty convinced that it was only irritant contact dermatitis, and we did see secondary reactions beyond. Now, when I do see those secondary reactions, it tends to be in those atopic dermatitis patients. And again, some of this is semantics, but what we need to realize is we're not just triggering irritant contact dermatitis in a vacuum. It can become the sort of the nidus to set off full-blown atopic dermatitis flares. And once the AD starts flaring up, that can happen full body. In general, although, again, I've seen this distinction fail repeatedly, but pure irritant contact dermatitis tends to be less itchy than atopic derm, and irritant contact dermatitis, it often gets us thinking more about irritancy. And when I hear from the patient, they only have on a scale of 0 to 10 for itch, they tell me I only have a 1 or a 2, I start thinking, okay, there's a good chance this patch test is going to be negative. And yet, repeatedly, they'll come back positive with relevant allergens where avoidance makes all the difference in the world for them. So these are some soft rules that we look for, but they're by no means, valid or reliable. Another issue that comes up that I think is very important is that irritant triggers may be more problematic with combined exposures or situational exposures. And this sometimes can be very puzzling for patients and for providers as well, because you would presume that if someone is being triggered by whatever, fragrances, surfactants, whatever it might be, Well, that it would have the same predictable effect every single time they're exposed. And that's not always the case. So, certainly in the atopic dermatitis patients, those who have more severe xerosis, as evidence of that more, profound barrier disruption, or when the atopic dermatitis is particularly flaring already, their personal care products can all of a sudden become very problematic for them. So sometimes patients will say, I don't need to avoid this because, in the summertime I can use this, whatever shampoo, conditioner, I have no problems. But then it turns out that in the wintertime, when their atopic dermatitis is flaring in a cold climate, all of a sudden that same product can be an issue. And so this kind of situational or seasonal relevance can become quite important in terms of counseling. We certainly see, for hand eczema, and not just hands, but other parts of the body, frequent water exposure. I think this is probably where it comes up the most. Showering and bathing practices come up a lot. I was taught as a resident that all atopic dermatitis patients are flared by taking long showers, et cetera. And, it turns out that that's probably not actually true for all patients. But even for those patients where excess showers do have a major impact, sometimes that's only the case in the wintertime in combination with extreme dryness from the lower indoor humidity and outdoor humidity, use of indoor heating, less outdoor time. And so when used in proximity with other irritants, whether in combination in individual products or temporally in proximity to each other, these are also issues that can come up. So use of harsh antibacterial soaps combined with the excess water exposure, right? The combination of the two can sometimes be an issue. So why does all this matter? Well, because despite what I mentioned at the get-go that this is not a sexy topic, this is the cornerstone of all management of atopic dermatitis. This is the step-up approach to atopic derm that is recommended by the ETFAD, atopic dermatitis yardstick, et cetera. Our first rule in medicine is do no harm. We recommend the non-medicated strategies as much as possible, within reason, but because we're trying to spare use of medication wherever possible and, using lifestyle modification. So we talk about trigger avoidance, about common allergens and irritants, but if you look at all the guidelines, it's literally, that's it, right? It's 2 words, right? Allergens and irritants. And there really isn't much guidance on beyond that. And it turns out it's really complicated to guide patients around these issues. What are some common triggers that come up in atopic dermatitis? And you would say many of these are not necessarily irritants in personal care products, but this is just from a list from a study that I published recently. You have environmental triggers, cold temperature, hot temperature, sweat can definitely be an issue. We've got fragrances in that mix. We've got plenty of other personal care products that come up as well, and skin allergens, irritants, et cetera. So there's a broad category, and even clothing we have to think about too, which, again, what would you call clothing? Should you call that an irritant? It's friction. It's rubbing against the skin. It will trigger the atopic dermatitis in absence of any relevant contact allergens. So you can call it irritant, you can call it what you want, but it's something that can trigger. And these triggers are common. All right, just to give you a sense of how much this comes up, in this particular study of adult atopic dermatitis patients, more than a third had at least 3 different itch triggers, and more itch triggers was associated with more severe disease and also worse disease control. And if you think about it, it makes sense. I mean, it's maybe obvious if you're seeing patients clinically, but if you've got 1 trigger, okay, you could probably avoid that reasonably well. If you've got 10 triggers, good luck. You're not going to be able to avoid that so easily, and you're going to end up using more medicines as a result. So to summarize, individuals with past or current atopic dermatitis have increased risk of irritant contact dermatitis from a variety of different sources and triggers. Even individuals with a history of childhood atopic dermatitis that is, burnt out, have increased risk of developing ICD, irritant contact dermatitis later in life. We talked about occupational dermatitis, hand dermatitis. There's many other groupings to think about. And then associations of irritant contact dermatitis include, more severe atopic dermatitis, filaggrin mutations, and occupation, as I mentioned, even in kids. And all patients with atopic dermatitis should be counseled on how to minimize the irritant exposures in the home and workplace. I think one thing, actually I'll come to this in a second, one thing I didn't mention because I thought it would be covered previously, and it was, but just to state what might be obvious at this point, because I didn't really talk about it, is how do we then make this diagnosis of irritant contact dermatitis? And it is a diagnosis of exclusion for so many patients, right? Because you need to rule out allergic contact dermatitis and you need to think about patch testing. And so for most, it becomes a diagnosis of exclusion where if after there's a negative patch test, then you would say, okay, it's not allergic, it's irritant in nature. And then for those of you who are, I assume everyone in the room is an atopic dermatitis aficionado, I would welcome you to the upcoming Revolutionizing Atopic Dermatitis Conference in Baltimore just in a few weeks. And I thank you for your attention.